So my job in the next few minutes is talk about how one assesses the severity as well as the natural history of bronchiectasis. So these are my disclosure slides. But I thought I would start, before I got into the topic of severity and natural history, just really, I think, echo what Dr. O'Donnell had talked about before in terms of some of the clinical things that we think about with bronchiectasis. So the first thing is, when should we suspect bronchiectasis? And clearly people who are symptomatic, people who have persistent, productive cough, who bring up daily, significant volume of sputum. She alluded to the fact that this diagnosis revolves over many years, so symptoms for many years is one of the red flags for the diagnosis of bronchiectasis. And for the docs out there, for the providers, if you get a sputum culture on somebody with recurrent respiratory tract infection and you isolate Pseudomonas, that's a patient you need to really focus on and really go the full distance to look for the diagnosis of bronchiectasis. Certainly people who have recurrent respiratory tract infections, if you have patients who get 2-3 courses of antibiotics for purulent respiratory tract infections, that's a patient who has bronchiectasis until proven otherwise. And certainly, again, Ann alluded to this before, I see many patients who come to my office who are diagnosed with COPD because they have respiratory symptoms, they get recurrent exacerbations, but the one thing they don't have is the major risk factor, and is they're non-smokers. So again, non-smokers who carry diagnosis of COPD, think again. And every once in a while, you'll see a patient who has expectoration of blood over an extended period of time who ultimately will have bronchiectasis. And I saw a patient like this just relatively recently. Now, how we approach the diagnosis, again, we confirm the diagnosis with an HRCT scan, but this is a very heterogeneous disease with multiple contributing conditions. So when we see patients in the office, we consider a number of factors. The age of the patient is important. If you have a young patient, and the age that I consider young is going up and up and up as I get older, but certainly younger patients under the age of 40 who have bronchiectasis, you need to think about immunodeficiency, you need to think about genetic causes like PCD, older patients, NTM, recurrent aspiration, etc. Certainly the presence of extrapulmonary symptoms, joint symptoms, swallowing dysfunction, GI symptoms can look for, point out things like connective tissue disorders, inflammatory bowel disease, things that ultimately we predispose to bronchiectasis. She also talked about the radiologic characteristics, which I personally find quite helpful. And then the microbiology. Again, if you get a sputum culture and you routinely grow staph in the sputum of a particular patient, think about cystic fibrosis. And to a lesser degree, allergic bronchopulmonary aspergillosis patients seem to have a particular tropism for Staph aureus. Again, in terms of the radiologic distribution, I find this very helpful. For people with focal disease or localized disease to one lung or one lobe, the differential diagnosis is quite limited. Sometimes a clinical history, an old history of a pneumonia, and other signs of airway obstruction are enough to make the diagnosis. But for people who have diffuse disease, multifocal disease, again, the differential diagnosis is a lot wider, and you need to cast your diagnostic net a lot further. In terms of what evaluation these people get, or we should get, again, there's not a lot of evidence-based help for us from the literature, but I wanted just to show you some recently published data. This is from the European Respiratory Society guidelines, and this was based on some review of the literature, and these are conditional recommendations based on data that's not particularly strong, but it's out there in the literature, and I wanted you to make you aware of it. The minimum studies that they propose are a CBC with differential count, looking for peripheral eosinophilia, lymphopenia, other evidence to point to immunodeficiency, for example. Everyone should have serum immunoglobulin testing, A, G, and M. They propose that people get ABPA testing with a serum IgE level, as well as aspergillus-specific Ig and IgG levels, as well as an aspergillus skin test. And they also recommend, and I agree with, especially early on, a routine sputum culture to look for dominant pathogens, particularly Pseudomonas. Obviously, other testing should be done in individual patients and tailored as dictated by the clinical data. In terms of CF, the ERS and the BTS propose that CF testing be done for anybody under the age of 40, so children and adults, up until the age of 40, and they recommend both sweat chloride studies and CFTR genetic mutation analyses. Again, a lot of debate about this, but this is what our European colleagues propose. And in older patients, those above 40, to consider testing them for cystic fibrosis if they've got upper lobe predominant bronchiectasis, again, if they've got persistent isolation of Staph aureus in their sputum, if they've got GI diseases or features of malabsorption, those with male primary infertility, and patients with recurrent pancreatitis. Again, your antenna for the possibility of CF goes up. In terms of PCD testing, Again, we see a fair number of patients with primary ciliary dyskinesia in our practice, and we really focus on patients that we elicit a history of neonatal respiratory distress, which, as Ken Olivier has taught us, is a really important historical perspective with the diagnosis of PCD. People who've got chronic rhinosinusitis or otitis media, virtually all of these patients have upper sinus disease and ear disease. And certainly if they've got infertility or dextrocardia, again, that's a major red flag. Workup for gastric aspiration should certainly be considered in selected patients. It's oftentimes, again, hard to make a cause and effect relationship between reflux and bronchiectasis, but in older folks with lower lobe predominant bronchiectasis, dilated esophagus on CT scan, again, an important thing to think about in approaching the diagnosis. And I just wanted to mention about bronchoscopy. Bronchoscopy certainly is not routinely warranted. We don't make the diagnosis of bronchiectasis by bronchoscopy, but it's helpful in patients that we're looking for a site of recurrent hemoptysis or to obtain microbiologic samples, obviously for NTM, as well as routine bacteria. Now, I wanted to show this Peter Cole's vicious cycle hypothesis, not so much to go over the pathophysiology as Ann did, but really to provide a conceptual framework of what we do to treat patients with bronchiectasis. Unfortunately, we don't have any FDA-approved therapies for bronchiectasis, but I think we do have some tools in our toolbox. Certainly, I think the mainstay of therapy for bronchiectasis is antibiotic therapy. Clearly, systemic antibiotics to treat acute infections, acute respiratory infections, and pneumonia are a mainstay of what we do. There's been a lot of interest recently on the use of aerosolized or inhaled antibiotics, tobramycin, aztreonam, more recently inhaled ciprofloxacin. Unfortunately, the clear-cut efficacy of these drugs has not been proven enough to get FDA approval. There's an ongoing trial, for example, of inhaled colistin, but I think this is something that we believe is helpful in a subset of patients, but ultimately we need to develop a bigger evidence base for inhaled antibiotics. Remember that recurrent infection and ongoing inflammation are part of the pathophysiology of bronchiectasis, so anti-inflammatory therapy are things that we consider clearly. The best evidence base we have for anti-inflammatory therapy is with macrolide antibiotics. Macrolides have very important immunomodulatory and anti-inflammatory properties. There have been 3 studies published in the relatively recent past that show that in selected patients with recurrent exacerbations, more than 3 a year, that macrolides, in fact, do decrease the incidence and frequency of these exacerbations moving forward. The caveat is in a group of patients that I see in southeastern Pennsylvania who have a lot of NTM disease, one has to be very careful not to use monotherapy with azithromycin or clobrothero, any of the macrolides in those patients. I can tell you that steroids, again, every time we talk about inflammation, we talk about steroids. In general, neither systemic steroids nor inhaled corticosteroids really should be used in patients with bronchiectasis unless they have underlying conditions where the benefit outsources the risk. Airway clearance, as you'll hear about later on, is critically important. It's one of the things that patients who are referred to me aren't on, and I can tell you that the experts in the field here are really preach the lesson of airway clearance and the importance in a group of patients with bronchiectasis. And then lastly, surgery. We know that it can be done with acceptable morbidity and mortality in selected patients with bronchiectasis as well as NTM infection. And then obviously the treatment of underlying conditions is very, very important and should be individualized for the patients that we see in our practice. So in terms of assessing the severity and prognosis, in general, the clinical course and the natural history of bronchiectasis are very variable. Some patients have minimal symptoms and infrequent exacerbations. I see them once a year, while others are greatly impacted, and you heard about from our patients about how significant that impact is. So our ability, unfortunately, to accurately assess severity and prognosis was for a long time an unmet need, but I wanted to show you some data that looks at the progress we've made in doing that in assessing severity and prognosis. Now, why do we care about bronchiectasis? Well, one of the reasons we care is because it adversely affects quality of life. And on this slide, we look at some data published about using the St. George's Respiratory Questionnaire, which is a well-characterized quality of life tool that's been applied broadly for a number of diseases of the lung. And if you look at the left-hand part of the slide, you see the SGRQ score. So remember that higher scores, a higher number means worse quality of life. And if you look at bronchiectasis compared to other airways diseases like severe COPD, parenchymal diseases like idiopathic pulmonary fibrosis, look at that. The impairment of quality of life is on the same spectrum as more common and severe other lung diseases. And more importantly, if you look at the subset of patients who have bronchiectasis who will also have chronic Pseudomonas infection, and about 30% of our patients will in fact develop chronic Pseudomonas infections, the quality of life is even worse, and it really rivals that, again, of other common both airways and parenchymal lung diseases. Now, early data gave us some hints as some of the factors that influence quality of life, the degree of dyspnea, the impact on FEV1, on objective measures of lung function. Sputum volume was implicated. Again, the more sputum is associated with worse quality of life. And again, the idea that patients who have Pseudomonas infection have worse quality of life has been borne out, and I'll show you the data over the next several minutes. Now, over the last several years, we've actually learned other lessons, and we've gotten a little bit more sophisticated at teasing out some of those factors that have a potential negative impact. One of that is the impact on a bacterial load, and high bacterial load as measured by colony-forming units has been linked to a higher risk of future exacerbations. The more bacteria, the higher the bacterial load, the higher the risk of future exacerbations. Along with that goes a future higher risk for hospitalizations for exacerbations, and also more prominent markers of lung inflammation. And interestingly, and not surprisingly, antibiotics reduce bacterial load and markers of inflammation, and may explain why patients may do better, not only for treatment of acute infections, but in suppressing exacerbations moving forward. Again, I just wanted to hearken again the data about Pseudomonas infections. This data comes from James Chalmers' work in the UK, looking at large groups of patients in the European cohorts. If you look at patients who have Pseudomonas infections as compared to other bacteria or patients who are not chronically infected or chronically colonized, people with Pseudomonas have a much higher risk of hospitalization and a significantly threefold higher risk of mortality compared to other gram-negative rods, compared to Streptococcus, or again, patients who don't have a dominant pathogen identified. And this will be a common theme as we talk about some of the tools that are out there to help assess severity and prognosis. Now, you've heard about exacerbations. And really, exacerbations are really important punctuators of the clinical course of a lot of patients with bronchiectasis. And Dr. O'Donnell alluded to the fact that most of us know it when we see it, but it's hard to define. But it's important to define because exacerbations have become one of the major primary endpoints for clinical trials, including those of inhaled antibiotics. So what you see on this slide are the work of both international group, both European and US investigators. We got together a meeting 2 years ago, and we did a Delphi approach, and we developed a consensus definition for pulmonary exacerbations, which you'll see here. So a patient with bronchiectasis who has a deterioration in 3 or more of the following key symptoms that you see there: cough, sputum volume and/or consistency, sputum purulence, changes in breathlessness and exercise tolerance, worsening fatigue or malaise, or hemoptysis, plus a physician or provider's decision to optimize therapy, be that antibiotic therapy, be that optimizing airway clearance. This is what we've come up with in a consensus fashion to define an exacerbation. The reason I defined it is, again, it's important for the providers in the audience to know where we stand on this, but also frequent exacerbations correlate very nicely with worse quality of life and prognosis, and I'll show you that in a couple of seconds. So what do we know about the mortality of bronchiectasis? Just like the issues of epidemiology, the amount of information we have about this is relatively limited. This is the best paper that I can come up with. This was from experience at the Royal Brompton in the UK. These were 91 patients that were followed in that center over a period of 13 years, starting in the mid-90s. 56% of these patients had idiopathic bronchiectasis. At the time they came into the study, the mean age was 52. And over that time, over that decade and a half, about 30% of patients in this cohort of bronchiectasis died of their bronchiectasis or died with bronchiectasis, and that compares to an expected death rate of only 15% for men and 9% for women who are otherwise matched except for not having bronchiectasis. Importantly, respiratory causes accounted for about 70% of the deaths, and the predictors that were identified in this relatively small study were older patients, those who had Pseudomonas infection, those who had more severe impact or diminution of their FEV1, and who had worse quality of life as measured by the St. George's Respiratory Questionnaire. So I wanted to show a case, and this is a patient of mine that I've been taking care of for a long time. I told him he doesn't know it, but he's become famous because I've shown his history and I've shown his CT scan so often, even though I can't obviously give you his name, but he's a 77-year-old gentleman that I've been taking care of for many years. He was diagnosed with bronchiectasis at age 12 after a pneumonia when he was 18 months of age. Tuberculosis was excluded at the time of his diagnosis. And this is what a CT scan looks like. And this is as severe bronchiectasis as I've seen. You can see that his entire left lung is really destroyed with severe cystic bronchiectasis, and he also has bronchiectasis in the right middle lobe. When he was seen, he grew up in the South, and a left pneumonectomy was recommended back in the 50s, but declined by his parents, and he actually did well over an extended period of time, both as a teenager, as an adult. He had children, he worked as a parole officer, and he was managed for many years with rotating antibiotics and chest physiotherapy measures, but the last few years have really changed the game for him. He's had a significant decrement in his lung function over and which one would expect from just age-related changes overall. He's developed quinolone-resistant chronic Pseudomonas infection. He now has several exacerbations a year that require IV antibiotics and oftentimes hospitalization. He produces 40 mLs of sputum a day. And unlike his previous years, he now clearly says that his quality of life has declined to an unacceptable level. So how do we assess the severity of this patient's bronchiectasis? Well, the last few years have brought us some very important tools, and one that I wanted to highlight was the Bronchiectasis Severity Index. This is a clinical prediction tool for disease severity. It was derived from a prospective cohort study in the UK of 608 patients, and it was subsequently validated in several independent cohorts. Importantly, patients with active NTM infection were excluded, and this tool relies on 9 parameters. And you don't have to memorize these. These will be available in the paper. But these are the things that they considered and used in the tool: the age of the patient, the BMI, FEV1, hospital admissions, the frequency of exacerbations, the level of symptoms of dyspnea using the Medical Research Council score, the presence or absence of Pseudomonas infection, infection with other organisms, and radiologic severity. That is the involvement of 3 or more lobes versus those with more localized disease. And you can see here, I think it projects pretty well. If you look at the scores, so 0 to 4 is mild disease, 5 to 8 confers moderate severity, and above 9 and above is severe bronchiectasis. And if you look at mild, moderate, and severe patients, it tracks very nicely with higher risk of exacerbations, higher risk and higher frequency of hospitalization, higher frequency of exacerbations, and it correlates with more impairment of quality of life and ultimately on mortality. If you look specifically at independent predictors of hospitalization, again, if you've been hospitalized before, if you have significant dyspnea with an MRC dyspnea score greater than 4, for people who have FEV1s that are severely diminished below 30%, who have Pseudomonas, and who have 3 or more lobes involved in HRCT, these are independent risk factors that we can point to that predicts the risk of hospitalization. If you look at mortality, again, some of the things that we've alluded to have shaken out of this particular tool. So older age, greater than 70, lower FEV1, typically less than 30%, people who are undernourished or have a low BMI, people who've required hospitalization, and those frequent exacerbators, those patients who have 3 or more exacerbations in the previous year. Again, these are independent predictors of mortality and adverse outcomes in patients with bronchiectasis. Another score that has been published and that has been used in a number of different forms is the facet score. This score classifies severity according to prognosis. It comes from Spain, and it was derived from an observational study there from 7 centers. Again, large numbers of patients, 819 patients. This is a little bit more of a user-friendly scale. It has 5 variables on a 7-point scale, and you can see the mild to moderate and severe categories based on the score. And on the right-hand side in the graph, you can see the points that are given for each of the 5 variables. So in general, this was also validated in subsequent cohorts to predict 5-year all-cause mortality. On the left-hand side, you see the initial construction cohort, and on the right-hand side, you can see the validation cohort. And what you can see is that patients, for example, with mild disease, in terms of mortality, actually do well. Mortality is relatively low over a period of follow-up over several years, over about 5 years, but people with moderate to severe severity of their bronchiectasis have, again, a higher 5-year mortality all-cause in this cohort. There's been a recent addition to the facet score. This was really an update of the score to include and expand the capacity of the original tool to predict exacerbations. This was called the E-facet score. And when you compare it to the original tool, again, it does quite similar in terms of predicting not only hospitalization and severity and mortality, but also again, frequent exacerbations in the future. So if you look at bronchiectasis mortality, how do the BSI and facet scores compare? So this was evaluated in a 91% cohort of patients followed since 1994, the same cohort that I showed you before about the mortality data. The median follow-up here is now 18.8 years, and it turns out that both scores were similarly predictive of 5-year and 15-year mortality. The facet did a little bit better for longer-term mortality, but both of these tools, I think, have provided us some other tools to look at severity and prognosis. Now, as I've mentioned, others have mentioned, bronchiectasis is a pretty heterogeneous disease, and I think we've moved a little bit away from classifying bronchiectasis simply according to the underlying diagnosis. So if you think about it, does a patient who have primary ciliary dyskinesia, what do they have in common in the long term with a patient with allergic bronchopulmonary aspergillose? They have bronchiectasis, but do those patients behave differently? So there's been a lot of interest in really defining clinical phenotypes, and phenotypes is an attempt to group patients based on common clinical characteristics. And I think this is the way that we're moving towards as we think about the natural history of bronchiectasis. Rather than looking specifically at etiologies, look at phenotypes and really do a better job at identifying those phenotypes. So one of the first papers that was published was a couple of years ago from Stefano Aliberti from Italy. These are 4 clusters that he identified, he and his coworkers identified in a European cohort of almost 1,200 patients that were followed over a period of 3 years, and they identified, again, 4 cohorts. Those patients who had chronic Pseudomonas infection, those patients who had other chronic infections, daily sputum producers, and those patients that had dry bronchiectasis. Now, I want to underscore the fact that just because you don't produce sputum, just because you don't have Pseudomonas, doesn't mean that, for example, you'll do well or necessarily. Again, you look at the mortality over a period of a year follow-up, mortality was pretty high. We need to flesh that out. The point here is moving away from looking at etiology and looking at these clinical phenotypes. And this is a paper I just wanted to highlight. This is hot off the press. This was from James Chalmers from the UK, who wrote a very nice paper that came out electronically before published in print in the Blue Journal. And he talked about, he and his collaborators talked about the frequent exacerbator phenotypes. This is really work that included 2,570 patients from 10 sites in Europe and Israel. And they looked at a whole bunch of characteristics of these patients over time. And what they found, and the most important part of the paper, is that prior and frequent exacerbations, typically those with more than 3 exacerbations a year, that group and that cohort were the strongest predictor of future exacerbations. There are other independent predictors of exacerbations, including Pseudomonas infection and, surprisingly, Haemophilus influenza as well, low FEV1, radiologic severity, and obviously the coexistence of COPD, which has been written a lot about in Europe, seems to be, again, an important comorbidity in these patients. The frequent exacerbators, specifically those with 3 or 4 exacerbations, also had worse quality of life. They had higher disease severity when you look at both the BSI and the facet, and increased mortality. But one of the interesting things about this paper is when they looked at all these patients, about 40% of patients either had 0 or 1 exacerbations. Now, about 40% had a lot, 3 or more, but a good number of patients had relatively small use of resources needed to treat patients with exacerbations. I thought that was an interesting sidelight of this particular paper. The other feature that's arisen in research over the last several years is the fact that bronchiectasis does not occur in a vacuum, that there are significant numbers of comorbidities. This was first published several years ago from our colleagues at the NIH, who looked at some of those attendant comorbidities. This was followed up more recently by the development of actually a bronchiectasis etiology comorbidity index. This looked at a cohort analysis of 986 outpatients, and they specifically wanted to look at the impact of comorbidities on mortality. The patients had a median number of 4 comorbidities, and in a very extensive and very elaborate study design, they identified 13 comorbidities that were independently associated with higher mortality, and that was called the BACI index. And the BACI predicts 5-year mortality rate, hospitalizations, quality of life across all BSI risk stratifications, and this was validated again in 2 independent cohorts from both the UK and from Serbia. So more to come about the impact of comorbidities on the clinical course of bronchiectasis. So let's get back to my patient. So older guy with a decline in FEV1, frequent exacerbations, and chronic Pseudomonas infection. If you apply the BSI and the facet, the BSI score is 13, the facet score is 5, and this obviously correlates and suggests that this patient has severe bronchiectasis. And this is the kind of patient that we have to pay attention to. These are the kinds of patients that we desperately need diagnostic and therapeutic armamentarium to alter the natural history and hopefully the prognosis in patients like this. So in summary, I just wanted to leave you with several thoughts. Again, the natural history and prognosis of bronchiectasis is oftentimes difficult to predict, but the good news is that we now have a number of validated tools that are out there, including the Bronchiectasis Severity Index and the facet. And the one thing that I clearly want providers as well as the patients and care providers to know is that there are specific factors that you need to pay attention to that appear to be associated with worse outcomes. Again, older patients, people with real embarrassment of their lung function as evidenced by the FEV1, chronic Pseudomonas infection, frequency of exacerbations, certainly greater than 3 over a 12-month period, and the comorbidities aspect we need to look a little bit more closely at. So I thank you for your attention, and again, I wanted to thank NTIR for their invitation.